اليوم إن شاء الله راح تكون آخر محاضرة ببيدياتريك موديول وختامها مسك إن شاء الله. راح يكون العنوان المحاضرة عن البيسكس اوف ديفورميتي كوركشن بالبيدياتريك ايج جروب. راح تكون يعني إن شاء الله محاضرة ممتعة عن طريق الدكتور رازي. المعلومات اللي فيها مهمة للجميع، ما راح يكون فيها تعقيد ولا راح ندخل بديتيلز ما لها خلينا نقول beyond your level as residents، بس ضروري الكل يعرف البيسكس تبع الديفورميتي كوركشنز والديفورميتيز الموجوده بالبيدياتريك ايج جروب. وفي عليها دائما اسئله بالامتحانات البورد وامتحانات كمان الاقامه. فدكتور رازي مشكورا عمل لنا محاضره ان شاء الله راح تكون ممتازه. وسيدي تفضل دكتور رازي.
الله يعطيكم العافيه ويمسيكم بالخير جميعا. ناصر, should I start sharing my screen?
Yes, please, sir.
Okay. بسم الله الرحمن الرحيم. صحيح موضوع ال deformity correction it is not only in pediatrics، يعني الموضوع أكبر من only in pediatrics، ولكن يعني حاولت أركز بقدر الإمكان على يعني what is it that we see in our clinic, what are the main principles in the management of pediatrics deformity correction, what do we do to these patients, how do we classify them, how do we analyze the pathology, how do we identify is it a deformity or a normal variant. هاي أحد أهم الأشياء اللي يعني بهاي المحاضرة راح نحكي عنها. الآن deformity by itself is defined as anything out of the normal. In pediatrics, it is classified into two main groups, congenital and acquired. الآن congenital deformities, it is any type of deformity that a child is born with. بشار الخالدي، بشار خوالدي.
تفضل سيدي يعطيك العافية.
كيف حالك؟ الله يسعد مساك.
أهلا وسهلا، كيف أمورك سيدي؟
أعطيني example على congenital deformity.
congenital deformity في عندنا ال TEV.
يا سلام عليك، TEV. Another type.
لمس.
anything a child is born with. أي شيء بخطر على بالك إذا بتتذكر شيء، أي شيء.
congenital أوكي. عم نحكي عن limb deformities إحنا بس per se ولا any deformity؟
any deformity that comes in your mind preferably.
أوكي في الباكجينج deformities اللي هم torticollis من ال TEV متراس adductus.
أحسنت رائع. Great شكرا لك. So it is a congenital deformity is any deformity a child is born with. Okay. تمام. تركي الغزاوي.
نعم سيدي يعطيك العافية.
كيف حالك؟ يسعد مساك.
الله يسلمك.
So the other type of deformities are the acquired deformities. Do you have any way or any classification or any descriptive term يعني يحكي لنا يعني شو أنا بقصد في acquired deformity in a pediatric child?
So acquired deformity is deformity that occur following, let's say, like traumatic deform after trauma, after infectious disease.
Then trauma is one of the causes of deformities developing in a child. Trauma. في other groups.
Infections.
Groups of causes.
Yes, infectious causes.
Infectious. أحسنت. Other groups. Malignancies. ممتاز. في أي شيء ثاني بخطر على بالك؟
Like vascular AVN or something.
Vascular ممكن، ولو إنه الفاسكولار ممكن يكون if not traumatic it may be congenital.
Yes.
And it may be yes, and sometimes it may be also developmental. Another thing is بالpediatrics بنشوفهم neuromuscular. Because the child was born normal in these cases, and later on, due to the neuromuscular pathology that the child suffered from, then there is a pathology which was acquired later on. تمام. شكرا تركي، الله يعطيك العافية.
الله يعافيك.
So going back to the congenital deformities, these congenital deformities are sub-classified generally into being simple pathology, a simple pathology that may or may not need an intervention from us. The other type are the deficiencies, whether the upper limb or the lower limb, and connective tissue diseases, where the child was born with a congenital disease or a congenital pathology like connective tissue related disease. For example, AMC, erythrograposis multiplex congenita, which is, by the way, not a diagnosis by itself, rather than a descriptive term of many diseases related to the connective tissue diseases. There are, I think, around more than 300 of diseases that they can be described as AMC. They present with almost the same pathology. So what are the principles of treatment of congenital deformity correction? حكى قبل شوي الدكتور تركي، لا مش الدكتور تركي، حكى الدكتور بشار عن TEV, which is one of the commonest pathologies or the commonest congenital deformities which are being treated in the pediatrics orthopedic clinics. So how do we treat them? We follow the principles. Most of the pediatrics congenital deformities are treated by stretching in the beginning. You start by stretching the deformity or the limb into the proper or the favored position up to around 3 months. And then you go into splinting, which is between the area of 3 to 12 months. And we don't usually think about reconstruction before 1 year because most of the time, the bone has not yet developed properly. So you need to know what are you going to be able to work on. Most of the bones are in the hands and in the feet are cartilage, hyaline cartilage. So you just can't work on them. You just give them time to develop, to ossify properly, to be able to understand what is the pathology properly, to study it, and for the child to become bigger, to be able to go for reconstruction. So if we apply the principle اللي قبل شوي حكينا على TEV، بيجوك الأولاد هذول عمرهم كم يوم بالعيادة، الأهل مرتعبين. You tell them, okay, now we'll start stretching. The Ponseti procedure is all stretching. It's all about stretching. You stretch and you put the cast to maintain the stretch that you have put. They put the feet in. بعديها, but once you reach the favored position, you go for splinting for maintenance to maintain the limb in the favored position اللي بدك إياه. بعدين we kept them up to around 12 months. على 12 months شو بنساوي بالTEV؟ بصير daytime free و only night time for maintenance، لأنه بالdaytime مجرد مشي الولد بدل العمر اللي بدأ يمشي فيه. This is by itself is physiotherapy, and we keep it on night time. Now going on to the principles of acquired deformity correction. So we said there are groups, big groups, trauma-related infections, malignancies, neuromuscular, and actually anything that the child was not born with is considered an acquired deformity. So you start by treating the cause. This is the first thing. You treat the cause of the acquired deformity. Most of the time it treats it. And then you go for the reversal of the pathology. If not successful, you go for reconstruction. نعطي مثال. بيجيك طفل عنده يعني عمره for example 2 years. بلاش 2 years هاي خليها 2 years. أقول لك 2 years. Severe جينوفالجم. بتيجي بتصوره ليفت ريست اكس راي، بتلاقي وبتسوي له فحوصات فوسفورس وكالسيوم وفيتامين دي، بتلاقي عنده والله الطفل هذا ريكتس. So there is a pathology led to a deformity which has been acquired. So you treat the cause. Just by treating the cause, you have reversed the pathology and you have treated the child. So you don't really need correction. This is why in pediatrics, one of the causes in pediatrics, it is a little bit different than than in adults. Another cause, if the patient has an infection, you start by treating the cause, and then you reverse the pathology and you study what is the deformity that has developed, and then you think about reconstruction if needed. Now, why is it important to treat deformities in pediatrics? Well, just like any other patient in the orthopedics department, we are looking for, most of the time, we are looking for the return of the function. Or the function is there, but you want to improve the function to be normalized. Or sometimes you just need to prevent the possible complications related to that. Another very important pillar in the treatment of deformity correction in pediatrics is cosmesis. It doesn't mean that in adult patients we don't care about cosmesis. We care about it, but in pediatrics it is a different story. Why? If you go back to the adults, they have developed their personality, their psychological condition, their character, their self-esteem, their self-image. They have already developed that before the deformity that has happened to them. But in a child, it is a different case, because the child has not yet developed his character, neither his self-esteem nor his self-image. So the deformity itself will lead to a huge psychological impact on a child, because the child doesn't know that he will be mocked by his peers in the school, for example. And this is one of the examples. نرجع لموضوع التي اي في، المحاضره اللي اعطاها الدكتور حيدر. لعند 4 سنين احنا تقريبا بنكون خلصنا السبلنتنج، والمشكله اللي موجوده عندنا وعند كل الاطباء اللي بالعالم اللي هي compliance of the family. ما في كثير compliance، قد ما تحاول تعامل الاهل وتفهمهم انه compliance at around 4 years بنفك الدينيس براون عن الطفل for maintenance of TEV completely. بيضل عندك دائما most of the time، مش دائما، most of the time residual deformity which will need some sort of، نرجع نحكي ايش؟ reconstruction. هاي residual deformity الدكتور فراس دائما بيركز علينا you have to finish and the treatment of the reconstruction of the child, those who are treated in our clinic. بدك تخلص معاهم قبل 6 years. ليش الرقم 6 years لما يجي يعني most of the reconstruction بيصير عندنا between 4 to 6 years. We are trying our best to finish before 6 years. Why? Because of the huge impact of cosmesis. الطفل على 6 سنوات he has a huge life event. He will be going into school, and this is where you need to have his feet fixed properly before he goes to that, because of the cosmesis, because of the psychological effect. And this is why it is an important pillar in the deformity correction of pediatrics. So how do we manage these patients? Like any other patients in any clinic in the world, we start by history. And what are the things important in history? If it's a congenital deformity, you're going to look for any congenital deformity related in the family. You're going to ask if the mother has been exposed to radiation, took medication, sickness, illness, and the mother fever, febrile causes. In the examination, you need to identify the pathology, the extent of the pathology, how much is this pathology, so whether it's congenital or even acquired. What is the extent? What is the impact? What is the level? How is it causing a deformity for this child? And then you go for the investigations, not only to diagnose, but only to analyze this pathology, like as we are going to be seeing upfront in the analysis of the pathologies in the photos upcoming now. So who are these patients and who are those who treat them? So you can classify them if you want to separate them. They are patients with deformities in the upper limb and patients with the deformities in the lower limb. The patients who have upper limb deformities, they are separated. These patients, some of them are treated by our colleagues in the upper limb clinic, and we appreciate how the big load they are taking. And some of these patients are treated in our clinic because whomever comes to us, we'll just treat, and whoever comes to them, they treat. We consult them, and they consult us. It is a teamwork rather than a one person work. Some other deformities like syndactyly, for example, where the problem is not the pathology. The patient presents to orthopedics, but the treatment happens at the plastic surgery clinic because the problem is in the sufficiency of the skin. There isn't enough skin to cover the bone. So you have to always keep in mind that this is always a teamwork rather than a one-man job. Going to the lower limb deformities, most of the lower limb deformities are treated in our clinic, in the pediatrics orthopedics clinic. So what is deformity? If we are going to talk about children, we have to understand that there is a normal variant, a big normal variant, a huge variant of normality in children. Like, for example, if you have an infant, look at this photo. If you have an infant with genovarum, this is normal. But if you have a 4 years old with genovarum, I start to think, okay, why did this happen? If I have a child who's 2 years old with genovarum, I will think maybe this is physiological. If a child is 4 to 6 years old with genovulgum, I'll say, okay, probably this is only physiological. So brings us back to the history. You take the history to recognize and relate the pathology that has been presented to you. Is this a deformity in the beginning, before starting about deformity correction? Is it really a deformity? Is it not a deformity? So you have to understand what is the normal development of a child, where the child starts by genovulgum in the lower limb, and then the child normalizes and then explodes into genovulgum and goes back to normality with different ages and different variations in these children. How some bone weakening diseases may affect them. Like, for example, خلينا نحط مثلا دكتور ليث حسينات معنا. طيب دكتور بشار العمري. بشار خلص اخصائي يا جماعه. دكتور مين معنا؟ معتصم غصاب.
يعطيك العافيه سيدي. تفضل.
هلا، كيف حالك معتصم؟
الله يسلمك يا رب.
اجاك تشايلد الطفل عمره 4 سنين، والاهل بيقول لك والله يا دكتور رجليه قوسات، ركبه مربوطه في بعض ورجليه مقوسات، يعني والقم. شو بتقول لهم؟ How would you approach this child?
Okay, at this age, it's a normal variant.
History, examination, investigation, always, even if it's a normal variant in your mind. The answer to an approach, treatment, management, you always start by history, examination, investigations. And then, yes, I would say your answer is correct, mostly physiological, okay?
Yes.
الله يعطيك العافية.
الله يعافيك.
شكرا. So, after thinking about investigations, you have had an idea about the child, the history of the child. You took history and you did an examination of the child. Now, most of the lower limb deformities in children in pediatrics age, we use lower limb scanogram, which is a single photo that has some parameters which are the most important parameter, let's say, is you have to have the child standing, weight bearing. If there are limb length discrepancies, you put blocks between under the shorter leg to level the limbs, and then you have to have the patella facing forward. This is very important because we have pathologies are not on only one plane, we have rotational deformities. So there is an agreement that you have to have the patella facing forward, and you take a photo, a single photo of the whole limb to analyze it. So how do we analyze it? We have to understand and to study the lines that we need to be able to analyze a lower limb, to understand what is normal and what is abnormal. Now, this is the first line we're going to talk about, the anatomic axis, which is the mid-diaphyseal line. You draw 2 points in the mid-diaphysis. Look here. So this is a point in the mid-diaphysis and another point in the mid-diaphysis of the tibia. ترسم خط بين these 2 points. This is the anatomical axis. If you go to the femur, it's the same thing. Mid-diaphyseal line, mid-diaphyseal point, another mid-diaphyseal point. You draw a line between them, and then this is the anatomical axis of the femur. Of course, anatomical axes are not always straight. We do understand that the physiological bowing of the femur states that we have to have an anatomical axis which is a little bit away from being straight, because this is the anatomy of the femur. So we put 3 separate points at the mid-diaphyseal points here, and we draw a line, and this is why it's, in this case, it's not straight. The other line we need to keep in mind is the mechanical axis. Now you have to keep in mind there are mechanical axes for each bone and mechanical axis of a limb, which is the line connected between the center of 2 joints, the 2 tips of the joints of that bone, for the femur, proximal and distal femur. This is the mechanical axis in this side. And on the other side, this is the mechanical axis of the tibia, from the center of the joint of the proximal tibia to the center of the joint on the distal tibia. And this is the mechanical axis of the lower limb. You draw it from the center of the joint, the center of the hip joint, to the center of the ankle joint. And that line, the mechanical axis line, should cross from the center of the knee. What does this mean? A mechanical axis is talking about mechanics. It's talking about energy transmission, where the weight is going to pass. If it is aligned properly, the energy will pass from the center of the hip to the center of the knee to the center of the ankle. And that is something we are looking for. This is normal, and this is what we want deformity to come back to by the return of the function. Now, in some bones, it has been recognized that a mechanical axis is the same as an anatomical axis, like as in the tibia. While in the femur, if you draw the mechanical axis, and which is from the center of the hip to the center of the knee, the distal femur, and if you draw the anatomical axis, there is a little bit deviation of these lines. Not deviation, there's an angle between them, which is the anatomical mechanical angle. Anatomical and mechanical angle of these axes, which is between 2 to 7 degrees. You don't have to remember these numbers. You have to know that there is a difference. What does this mean for us? Now, Sensei says balance is achieved when the mechanical axis of the limb in the frontal plane passes through the center of the knee, where there is a mechanical axis deviation is 0. So this is what we are looking for. We are looking for balance. Another line is the joint orientation line. What is a joint orientation line? So it has been recognized that each joint has orientation. If you look at the frontal plane at the ankle joint here, this is the plane, the joint orientation line. And this is how we draw it. And the other plane, lateral view here, as you see, sagittal plane, this is the joint orientation line of the ankle. And this is the joint orientation of the knee, which is the meeting of which is drawn by 2 lines, not only 1 line, the joint orientation of the proximal tibia and the distal femur. Why am I saying 2 lines? It will come later because there's something called joint convergence line. Sorry, joint convergence angle, and I'll tell you why it's important later on. Now on the sagittal plane, look at the knee joint. This is how we draw the joint orientation line here on the distal and proximal tibia, and this is with growth plate or without growth plate, how we draw the joint orientation line of the distal femur. Very important joint orientation line, which is in the proximal femur. It is drawn between the center of the hip joint to the tip of the greater trochanter. Now we have seen the mechanical axes and how it's drawn, the anatomical axis and how it's drawn in the lower limb, and the joint orientation lines. From these lines, if we draw them, we analyze the limb, we're going to have angles. Just to have some agreement on some points here, it has been agreed in the orthopedic community about these abbreviations or nomenclature. A small a or m means anatomical or mechanical. Capital, all the other letters are capital. M, L, medial lateral. P, D, proximal distal. F, T, femur tibia. A, angle. So anatomical, mechanical. M, L, medial and lateral. P, D, proximal and distal. F, T, femur tibia. A, and for the angle. All of this gives us this view. Keep in mind, you don't have to remember the numbers. This is just an algorithm that you will find when you are working with deformity correction, but you have to understand what are the points you have to look for when you're analyzing the lower limb. Okay, so on the left side, on this side, on the yes, the left side here, this is the mechanical axis. And from this mechanical axis, with the joint line or joint orientation lines, we're going to have angles. نحكي دكتور رفعت رواشده.
سيدي تفضل.
So if you have this joint orientation line of the hip, and this is the mechanical axis, بيطلع عنا angle. الانجل هاي شو اسمها؟ شايف انا السهم وين؟
M for mechanical.
Mechanical. احنا lateral ولا medial للجوينت؟
لا lateral.
Lateral.
Proximal.
Proximal.
Femur angle.
Femur angle. So don't be frightened from these new multiple abbreviations. It's just describing the place it is at. So the one below it is mechanical, lateral, femoral angle. Okay, so what about this one? شايفها؟
Monitor سيدي وين؟
Down on the right side. You have to look. This is anatomical axis now. It is not mechanical axis. You see?
سيدي بس سيدي انا مش شايف المونيتور لانه الصوره عندي شوي.
اوكي خلاص ما في مشكله ما في مشكله. دكتور محمد الصرايري.
زوم شايف
الشاشه دكتور محمد؟ دكتور عبد الله الحوراني.
سيدي سامعك.
سامعني محمد؟ اوكي.
سيدي
محمد شايف الماوس وين؟
سيدي شايفه.
هاي تقدر تحكي لي شو هاي؟ what is this abbreviation for which angle? What is
anatomical lateral distal femur angle.
Anatomical lateral angle. So this is it. It's so simple. You just do, but what is more important is what is an acceptable scanogram. We said there are some criteria we have to make sure before analyzing the limb, otherwise we'll be just going into the wall. You have to analyze on a proper view where the patella is facing anteriorly, and then you draw your lines and you have the references of what is normal and what is abnormal. You know the normal variability between children, what is normal, when is it normal, and when is it acceptable. And then you start analyzing accordingly to decide, is this pathological or is it not? Does it need treatment, or is it something that will just abolish by itself or be treated by neglect? Another angle is the angle that we have talked about, which is the joint lateral convergence angle, which is around 0 to 2 degrees. Some say it is 0 to 3 degrees, which is the orientation of the knee to the distal femur to the proximal tibia. Another important angle, or not angle, it is something called the mechanical axis deviation. جابوا مجموعة كبيرة من الناس, normal people, they studied and analyzed their lower limbs, and they found that there is a little bit of deviation in the normality, within the normal variability, the deviation of the mechanical axis from the center of the knee. So if you draw a line from the center of the knee, from the center of the hip joint to the center of the ankle joint, and it didn't cross perfectly in the middle of the knee joint, if it's within the medial axis deviation, mechanical axis deviation, up to around 8 millimeters. So you can be, this can be accepted as a part of the normal variability. So this is the mechanical axis deviation. Okay, Dr. حمزة محمد حسين.
سيدي يعطيك العافية.
هلا حمزاوي، كيف حالك؟
ولا سيدي الله يسلمك.
طيب إذا حكيت لك عندي هذا الطفل إجاك على العيادة، الصورة هاي اللي شايفها قدامك، الطفل هذا عمره 1.5 سنة.
Yes.
بقول لك والله يا دكتور يعني شوف لنا شو رجلين الولد. This is one of the commonest cases presenting to our clinic. How would you approach it? What would you say? What would you do?
I will start my approach with the history, physical examination, and with investigation.
أحسن. تمام.
By history, I will. It's important to know.
I accept this. عمره 2 سنين. Is this considered physiological? May think that this is abnormal.
This is abnormal, sir.
It shouldn't be. Yes, in what we know in the development, it shouldn't be at this age presenting with this deformity. طيب إذا حكيت لك هذا الطفل عمره 5 سنين، اختلف الحكي؟
Yes, sir.
شو؟
Yeah, it may be a part of normal developmental process.
Exactly. It may be part. Yes. أحسن شيء عجبني إنك قلت it may be. Yes. Most probably it is part of the normal development of the child. طيب رائع. إذا حكيت لك الطفل هاي الصورة لطفل عمره 9 سنوات.
I will not accept this. يعني I will look for a pathology.
You will look for a pathology. لقيت pathology يعني خلينا نحكي ما في cause of this pathology, but you have this pathology and you want to treat it. How will you correct it? Do you have any idea?
No, sir, I don't have any idea.
Okay, الله يعطيك العافية. شكرا حمزة، الله يجزيك الخير. Well done. الدكتور عبد الهادي.
الو هلا سيدي. هلا سيدي،
يعطيك العافية.
الله يبارك فيك الحكيم.
Okay, this child is 9 years old. We have established that this child has genovalgum. We do not accept this. We want to treat this child. How will you manage this child. خلصنا أخذنا history, examination, investigations. We have done lower limb CT scanogram أو scanogram. It has been accepted. We analyzed the limb by the mechanical axes, anatomical axis, the joint orientation lines, رسمنا الangles, تفرجنا. We don't accept this.
هلا سير المانجمنت تبعتنا depend على الايج اوف ذا بيشنت، يعني حسب قديش ضايل في يس حسب قديش في عندنا ضايل growing for this patient. So we may be
يعني في برنسبل معين بدك تشتغل عليه.
Yes, يعني we can manipulate with the growth plate to arrest مثلا one side of the growth.
So you want to guide the growth.
Yeah.
So you want to treat him by guided growth control.
Yes.
Great, ممتاز. طب ليش ما تسوي له osteotomy وتقص العظمة ب5 دقائق؟ شغل عليك بتاخذ انت ربع ساعة، بتقص العظمة بتحطها زي ما بدك وبتنام ليلك طويل مرتاح ومكيف، والولد بعد شهر زمن بتكون ريحت راسك من يعني كل الازعاج اللي بده يصير عليك وضغط العيادات والهاي. Why not do it in half an hour and finish the job and that's it?
إنه to do like an osteotomy is there.
Yes, شو رأيك؟
So I think if we can preserve aggressive or invasive procedure for the last result, it's better.
Yes, definitely. كلامك صحيح دكتور عبد الهادي، الله يعطيك ألف عافية. مش بس أنت رأيك ذكاء، وهذا الدكتور بيتر كمان يعني أحد جهابذة عظام الأطفال، له مقولة مشهورة جدا اللي هي إيش؟ Osteotomy is a salvage procedure in children. Osteotomy is a salvage procedure in children. So you go for something called guided growth control in most of the cases. And these are some of the commonest cases اللي هي angular deformities in pediatrics اللي بيراجعوا عيادة pediatric orthopedics. So deformity correction by guided growth له أسماء كثير راح تلاقوا بالليترشر، فيعني بدك تعرف إنه في أسماء كثير وبالتالي ما تتلخبط لما تشوف اسم بيختلف عن اسم ثاني. In some literature, it's going to be guided growth, growth manipulation, growth plate manipulation, hemiepiphysiodesis, mechanical hemiepiphysiodesis, temporary epiphysiodesis, temporary hemiepiphysiodesis, temporary mechanical hemiepiphysiodesis. All of these names, كلياتهم في الأخير, you are guiding the growth. Don't be intimidated by names. They all are talking about guiding the growth to correct the deformity. So we have to have some prerequisites for the guided growth deformation control. First of all, it has to be an angular type of deformity where the physis has still some sufficient growth potential. And it has been found that any plane deformity, in any plane, in the sagittal, in the coronal, and even in rotational deformities, guiding the growth can correct it. And also they found in literature that most commonly the coronal plane is the best to respond, and also the coronal plane of the knee is the most in the coronal plane to respond. Just a little bit about history. كيف الناس يعني كيف تطور هذا الموضوع خلال الزمن. سنة 1862 هويتر المشهور بالعظام كتب بحث إنه والله there's pressure on the epiphysis affects growth. How? He doesn't know. بس حكى إنه he found that pressure on epiphysis affects growth. Then came Volkmann بعديه ب7 سنوات. He said changes in compressive forces cause asymmetry in growth of a joint. الآن بسنة 1933 اجى فيمستر ونشر في الجورنال JBGS نشر ايش؟ الريزلت تبع الكونكلوجن Operative Assessment of Longitudinal Growth. So he found that operative arrestment of longitudinal growth of bones in the treatment of deformities. أول واحد فكر في إنه هذا الموضوع can be used in the deformity correction واللي هو فيمستر. إجا حاس سمع هذا اللي حكى شو قال فيمستر، قال والله deformity correction let me try it on puppies. جاب شوية كلاب وسوى ايش؟ reversible hemiepiphysiodesis. يعني جاب خيطان figure of 8 خيط الهاي with a figure of 8 loops around the puppy's faces, and he found that this pathology or this thing is reversible. بعدين اجى بلاونت اللي اكتشف بلاونت ديزيز سنة 1949، قرأ كل هالليترشر هذا وفكر في موضوع ايش؟ How am I going to be treating? How can I use this information to treat the angular deformity of Blount disease? So he found that you can control bone growth by epiphyseal stapling, which was a preliminary report in 1949. And this is the staple as you see in the photo. Look at this child. He has a genovulgum. The faces are still open. In the middle picture, staples have been applied on the apex of the deformity. With growth, deformity has been corrected. اجى واحد اسمه ميتزوا قال طيب انا ليش ما استعمل سكروز؟ انا شو بدي في الستيبلز؟ Sometimes you can't use staples. Like look at this proximal femur X-ray. How are you going to use a staple in this? So he used percutaneous epiphysiodesis using transphysial screws, PETs, and he used it all around, and he had magnificent results. Look at the X-rays on the one on the left, how it developed even in some cases where you have like genovulgum, coxavulgum, and then it was resolved just by a simple screw. In 2007, the magnificent finding or the magnificent use of the hinge plate by Stevens, tension band plate it was called in the beginning, and then hinge plate, 8 plate, all are the same name of the. Okay, so what is the etiology of the angular deformity? You have to understand زي ما حكينا قبل شوية what is the normal development and what are the physiological variances between children when even in some cases it can be considered as normal, in others it can be considered as abnormal where you have to be going to treat it. In some cases it is post-traumatic partial growth arrest, sometimes in the infantile or adolescent tibia vara, in some skeletal dysplasias or metabolic bone disorders. Regarding the indications, well, it's simply a clinically unacceptable deformity in a patient with open physis. You have a child, you have an open physis, the deformity is clinically unaccepted. In these children, the risk of osteoarthritis has been cited as a reason to manage angular deformity. This is one of the reasons. They have found that knee varus and valgus was associated later on with osteoarthritis. The child is left. Varus and valgus malalignment increase, if you analyze it mechanically, it increases the load medially or laterally on the tibia plateau itself. Now, they found that sagittal plane deformities can also be managed by guided growth, although a little bit more difficult and more demanding, but they can also be managed in any plane. But you have to keep in mind what is the adequate growth potential for these children. Is there still enough growth potential remaining to correct my deformity? And this is a very big question. We'll be talking about it now. So how do we assess these patients? We go back to the analysis like any other patient. We start by history, physical examination, and then we go for radiological imaging. And in some cases, we go for genetic or metabolic evaluation in special cases where you suspect, where you have from your history and examination some suspicion that you may need some other ways to evaluate your patient. So in these children, you have to evaluate for limb length. If there is any limb length discrepancy, you have to examine them in the coronal and the sagittal plane. Very important to recognize that the patient has hyperlaxity of the ligaments, where you will have some sort of recurvatum deformity. This will affect your X-ray. This will affect your evaluation. So if you don't recognize this in the examination phase, you're going to miss it in the analysis later on. The patient should be examined in standing position, in static position where he's not moving, and where he's walking, and even while he's running. The stability of the knee joint should also be assessed. We said that we need, in the radiological imaging, we need standing films from hip to ankle, a single view with the knee facing anteriorly. We analyze the mechanical axes, which is the line drawn from the center of the hip to the center of the ankle. Prerequisite is, as we said, that the physis should be open, and that is something that we assess by radiological imaging. And the joint should be congruent. Look at this case. This is what the mechanical axis of this child with skeletal dysplasia, I think. Yes, it is a skeletal dysplasia, and this child has genovarum. Look at the mechanical axis and how much deviation of the mechanical axis from the center of the knee. The congruency of the joint is also paramount. Look at this X-ray, for example, where we thought that we needed an MRI after the X-ray, and we were right that we needed the MRI because we found that there is a bar here, a bar which was the cause of the angular pathology or the angular deformity that has developed in this child. Part of the radiological imaging is determining the skeletal age. You know that the skeletal age is not the chronological age. So a child might be 7 years old, for example, but his bone age may be less or more. So we need to look for the skeletal imaging. You have algorithms for that by doing a left hand X-ray or the elbow X-ray. We know the mnemonic or the abbreviation of CRITO. We can also do that. But you can just send him to the radiology and you can ask for the skeletal age, which will help you in recognizing what is the growth potential needed for the child. So we go for hemiepiphysiodesis most of the time. Most of our patients are patients with skeletal dysplasias related to trauma or even related to. So what are the principles we are working in? We're talking about first of all Heuter-Volkmann law. حكينا عنهم هذول قبل شوي بالhistory of that history of the management or history كيف it developed. Heuter-Volkmann law is simply if you compress one side, the compression and traction. If you compress one side, decreases hypercellularity of the growth. Traction on the other side increases hypercellularity and growth. They found that there is another principle which is called the rebound effect in the correction of the angular deformities. What is rebound effect? Rebound effect is when you apply the principle of guided growth and you achieve correction, full correction. Well, do I need to keep this implant? No, I have to remove it. Okay, so they found after you remove it, there's a little bit of deformity recurring, not the whole deformity, but the residual part of this deformity recurs. So they found they named this effect as the rebound effect. So to solve this problem, they said, okay, let's just overcorrect just a little bit to respect, because we know that there will be some sort of rebound effect in these patients. Another thing you have to understand in the principles of managing of these patients is that there are sometimes your management sometimes causes early closure at the compressed, which is a rare thing, but you have to understand it as one of the principles. As we said, a huge question is the timing of hemiepiphysiodesis. So Bowen et al. Developed a chart of coronal plane deformities about the knee. You need some data, which was, they collected the data from Green-Anderson growth remaining charts, the skeletal age of the child, the physial width. And they put it in an algorithm, a chart. Collect the data and you plot it accordingly to the skeletal, the bone, and you determine years old based boys for tibia or femur, and according to the angular deformity, it gives you the best time, or not best time, the potential of growth remaining for your child to be able to decide what is the best timing of your surgery. Another way now, which is easier, this application is called multiplier. It gives you any deformity, the timing for any deformity, lower limb congenital deformities, developmental, growth remaining, bone length, angular deformity. One example for here, look. This is an example of the tibia, the physis, the date of birth, the age of the child, length of the bone, the angular deformity. So it gives you here that for this child, age of hemiepiphysiodesis of proximal tibia physis is 13 years. If you do the surgery now, staple may be removed. So now is 7 years. The age is now 7 years. If you do the surgery now, the staple may be removed at the age of 9. So this really helps you so much. But still, the most important thing is your analysis. You're not going to put the staple or the hemiepiphysiodesis or guided growth method and leave the patient. You're going to keep on following him. Each time you analyze by the mechanical axes and the angles, and you decide when is the best time. This is the best way to be on the safe side and treat your patients properly. So what are the types of guided growth? You have temporary and permanent. Temporary, staples, screws, and tension bands. This is one example of the staples. They correct sagittal or coronal planes, and they must be extraperiosteal. If you reach the periosteum, then you have violated the physis and the zones of Reinwehr and the blood supply of the physis. So you don't need to, you must stay away from them, and you must stay extraperiosteally. You have to respect that there is a rebound effect, and you have to measure for that. You look for a little bit of overcorrection, which is a recommendation to be successful. So what are the disadvantages of staples? They may break, they may bend, they may migrate, and there is a potential of physical arrest. So what about the screws of Metazoa, who has found it on 1998? You can use it percutaneously. You can cross the physis. Through the physis, you cross it, and a question here comes: if I'm going to cross the physis, am I not going to damage the physis? So a paper has been published in 2007 where it has said that since 1998 until 2007, not a single case of permanent physical damage was reported, as they say. And they found that in these cases, varus correction is faster than valgus correction. Nobody knows, probably they think probably it is related to the biomechanics, but nobody really knows. So this is one example. Look at the mechanical axis on the picture A. On picture A, you draw a line from the center of the hip to the center of the ankle. There is a deviation, mechanical axis deviation laterally in both lower limbs. Metazoa screws, pit screws have been percutaneous screws have been placed, and the mechanical lines were corrected, and then the screw was removed after respecting that there may be some sort of rebound effect. So this is part of the correction in this deformity. What about the tension band plate, which is the state of the art now in the correction of the angular deformities? Look at the principle. It is very simple. You put it on the apex of the deformity, and then you catch the growth on this side where new bone is being formed on the tension side and decreased cellularity on the compression side, and leads to the correction of the lower limb or the limb with the angular deformity. So why is it the state-of-the-art plate and these types of deformities? Because of the ease of application. Lots of you guys came to our operative theater and have seen how simple you can apply the tension band. It has an excellent widespread use. They found that it has 30% higher rate of correction and related with any type of permanent physical arrest, and there are multiple sizes for different sizes of children. So they found that sometimes there is an implant failure, which has been reported by Sherlock et al. He has found that high rate of implant failure in Blount disease, which is a little bit resistant, and we know that. So due to this implant failure, they have modified the design of the plate with the hinge inside, and this is hinge. Because of the hinge in the middle, it allows more angular correction without applying tension on the screws itself. So the load of the deforming forces is distributed along the screw and the plate and along the hinge, which will allow better correction with less failure of the implant. Now, what about permanent hemiepiphysiodesis? Well, you have to go wait for skeletal maturity. So it has to be near skeletal maturity because it's permanent. Well, it is an attractive option because it eliminates implant-related complications. And there's no rebound effect. You just do it once and that's it. It can be done open or percutaneously. So this is Femister, South Arathine. He presented this also. The open hemiepiphysiodesis, you just bring a block of bone and you place it over, you implant it over the growth plate, and this is an open hemiepiphysiodesis where you stop the growth at that side. Another way is you just go to the physis and you just destroy it either by drilling, multiple drillings, or you corritage it, and this is a percutaneous hemiepiphysiodesis. Now, percutaneous uses smaller incisions, shorter hospital stay, reduced need for femoral formal physiotherapy, sorry, and of course, in the literature, there are several series which have demonstrated excellent results. What about complications, which are many of complications? There are general complications, there are infection, swelling, and stiffness, and some hardware-related, like implant extrusion, breakage, or even prominence. So the incidence of stable extrusion of breakage is relatively high. Extrusion that requires reinsertion is about 2 to 8%. So some of the complications are growth-related, like undercorrection or overcorrection and permanent physical damage. So this is one of the important things as to why you have to, in the history and the examination, you have to select the proper patient who you will be able to successfully treat. Like, for example, we had one patient who had an angular deformity. She was the perfect candidate medically, but sadly, she was not socially or socioeconomically one of the best candidates. We placed the angular plates, and then after 2.5 years, she presented with an extreme deformity on the other side. She had presented with severe genovarum. We removed the plate and we put it on the other side. And then she disappeared again. After 2 years, she came back with the deformity on the other side. So this teaches that, well, patient selection is sometimes one of the best the cases. And in these cases, osteotomies is not a salvage procedure because of the patient who has been selected for the proper decision. Now, hemarthrosis and knee effusion can happen, which will usually resolve by 3 weeks. Coming now to the take-home message, different types of deformities need different approaches. Normal developmental variance between children. You always come back to the history, the examination, and then investigations to be able to analyze the deformity. In the management of lower limb deformities, analysis is important to the diagnosis of the pathology or the deformity to be able to treat it. Keep in mind that osteotomy is a salvage procedure in children. الله يعطيكم ألف عافية.
الله يعطيك العافية سيدي، شكرا جزيلا لك على المحاضرة القيمة والممتعة الصحيح. يعني أنا بدي أحكي بالنسبة بس لموضوع deformity correction. لا تكاد تخلو عنا لستة من لستات عملياتنا في جراحة عظام الأطفال من deformity correction case، سواء باللور لمب أو الأبر لمب. والمبدأ guided growth control هو حاليا عندنا يعني مطبق بشكل يعني تام، واغلب حالاتنا بنستخدم الهنج بليتس اللي شرح عنها زي ما شفت الدكتور رازي حكى عنها باستفاضه، وموجوده عندنا ومتوفره، والزملاء المقيمين اللي داوموا معنا بالتيم وشافوا انه احنا كيف بنشتغل بهذا الموضوع. احنا ليش حطينا محاضره الديفورميتي كوركشن من ضمن البيدياتريك موديول؟ لانها اتس ون اوف ذا موست كيسز اللي احنا بنشوفها بالعياده، واحنا كثير بيجونا مرضى على العياده بيشكوا من الديفورميتيز. يعني زي ما حط الدكتور رازي اول المحاضره انه بيجيك كثير اطفال على العياده، الاب بيحكي لك يعني في عنده بوينج، في عنده فالجس، how you approach these patients, this is one of the most important subject او الجول of this lecture. يعني how to approach these patients. بدك تعمل لهم عمليه reassurance، بدك تشوف is it congenital, is it acquired، بدك تروح المريض، بدك تعمل له فحوصات. كثير مهم هذا الشيء. انا الصراحه بدي استغل الفرصه واطلب من الدكتور فراس ابراهيم سيدي اذا بتحب if you may say some words please.
مساء الخير للجميع.
مساء الخير يا سيدي.
الله يعطيكم الف عافيه. يعني صحيح برنامج مرتب ومحاضره رائعه. دكتور رازي covers everything للريزيدنت، وعقب عليه الدكتور اياس. يعني انا يعني بتمنى من المقيمين يهتموا بالبيزك نولج تبع الديفورميتي كوركشن. it is a common problem، وحتى بالامتحانات راح تشوفوا حالات من الديفورميتيز، وبنتفاجأ بعض الأحيان إنه بعض الزملاء they are not aware of describing a deformity. Now, the description of a deformity هو هذا بداية المحاضرة. How you describe a deformity is one of the important things اللي بتعطي impression إنه you are knowing what you are looking about. So يعني description of the deformity مهم جدا. اللي بستغرب وبشوفه بعض الأحيان، خليني أعطيكم من الشغلات اللي شفتها بالامتحانات خاصة بالبورد، إنه مريض من المرضى اللي جبناهم عنده bilateral genovarum، فبتستغرب إنه الكانديديت he does not look to the major deformity و start describing lower limbs. الشغلات اللي بيعلموها لبعض المقيمين إنه there is no hair loss, skin is normal، اللي مش عارف إيش، وبتطلعش على deformity اللي هي يعني من بعيد أي واحد بتطلع عليها اللي هو مش دكتور بقول لك إنه في عنده مشكلة بالركبة. فموضوع deformity is very important very common. You will face it in the general and in the specialized clinics. والمانجمنت تبعه البرنسبلز اللي اخذتوها اليوم هي البرنسبلز اوف ديفورميتي من البيزكس للادفانس نوليدج. الدكتور رازي ما قصر واعطاكم الشغلات البيزكس والكمان الادفانس اللي ممكن تحتاجوها في المستقبل. I hope انه نركز على زي ما حكيت النقاط المهمه جدا. description of the deformity، نعرف الديفورميتي هذه. يعني انا المره الماضيه بسال واحد من ريزيدنت شو معنى جينو، ما اعرف شو معنى جينو فالجم وجينو فارم. جينو اول كلمه ما اعرفها، فيا ريت نركز على الديسكريبشنز انه جينو فارم جينو فالجم، بعدين نعرف الكوزز والاتيولوجي والمانجمنت. بتكون انت يو كفر موست اوف ذا توبيك. صحيح برنامج المحاضرات هذا رائع جدا ومفيد، اللي قاعد واستمع اكيد استفاد كثير. كل التوفيق لكم جميعا والله يعطيكم الف عافيه.
شكرا سيدي، شكرا لك، الله يعطيك الف عافيه. شكرا على الملاحظات اللي قدمتها، وبتمنى من الزملاء المقيمين ياخذوها بعين الاعتبار، لان this is the target of our scientific program انه to cover most of the aspects اللي احنا ك orthopedic surgeons بنحتاجها و at the level of the resident. شكرا سيدي. دكتور رازي if you have some words please قبل ما ننهي.
شكرا لك، الله يعطيكم الف عافيه، واي شيء فيها اسئله انا جاهز.
سيدي احنا بموضوع الاسئله احنا عشان ما نطول على الشباب بالعاده if they have any questions they post it in the telegram group للساينتفك كوميتي. شكرا للجميع. اوكي شكرا للجميع، الله يعطيكم العافيه. شكرا دكتور فراس على حضورك معنا، وشكرا دكتور رازي على المحاضره، ونتمنى لكم التوفيق. ونذكركم بالموك اكزام ان شاء الله راح يكون يوم السبت، او الدكتور ناصر راح يعطينا ان شاء الله الموعد والتوقيت. شكرا وتصبحوا على خير، الله يعطيكم العافيه جميعا. شكرا.
الله يعافيكم.